I'm Dr. Stuart Menakar from the Palo Alto Medical Foundation, Los Gatos Center. Welcome to Health Connections on KCAT television, Los Gatos, Montserrat. On today's episode, I'm here with my colleague, Dr. Mark Golod. He's from our Department of Orthopedic Surgery. Welcome, Mark. Very nice to have you.
Thank you.
So let's start, Mark, if you would please explain to our viewers a little bit about yourself and why you decided to become an orthopedic surgeon.
I grew up in New York City, and my father had a workbench in the basement that I gravitated to from an early age. My mother decided she was going to have a son, the doctor, and the two fit. I am now an orthopedic surgeon.
And we're very happy to have you as part of our team. Tell me though, where did you train? Where did you go to medical school and do your resident training?
I went to medical school in Boston at Tufts University and came back to New York University, where I did my residency at the University Hospital at Bellevue, which is a very large city hospital, and at the VA hospital. After that, I did a fellowship in joint replacement surgery at Stanford University out here and stayed.
On today's program, we're going to focus mostly on the kind of work that you do. But we know that many of our orthopedic surgeons now subspecialize and have additional training, or what we call fellowship training, like Dr. Golod does. But most now have subspecialty training in things like hand surgery and would take care of hands, wrists, and elbows primarily, spine surgery, and other parts of your skeleton in their subspecialty. So Mark, let's start, if you would please explain to our viewers, what does an orthopedic surgeon do?
We take care of the musculoskeletal system, which is not only bones and joints, but also the muscles that propel them and allow you to walk and sit and coordinate the locomotion of the human body.
And when people think about orthopedics, besides being carpenters who learned on their father's workbench, a lot of us think about fractures. So broken bones, a very common reason a patient would end up needing to see an orthopedic surgeon. So tell us a little bit about fractures and how you care for them, please.
Well, the bones have a certain strength, and when that strength is exceeded, in engineering terms, it's the yield point. The bone might break, and it will break in different patterns depending upon the energy that's dissipated across them, and they have to be dealt with differently depending upon what bone and the age of the individual and the function necessary and so on and so forth. Joints in particular are very critical to fix exactly correctly so that the joint can still function normally and so that the patient doesn't develop arthritis afterwards. So depending upon the location of the fracture, the nature of the fracture, the age of the patient, on and on and on. There are very many different ways to take care of different fractures.
So I recently had the misfortune to break my hand, and I didn't get to see Dr. Golod. I saw one of our colleagues who specializes in orthopedic surgery of the hand. But I know from that experience that you guys, the doctors, work as part of a team. One of the things we value at the Palo Alto Medical Foundation is a team approach to care with our primary care doctors, who sent me to the orthopedic surgeon. But also within the Department of Orthopedic Surgeries, you have a team of other doctors who do different kinds of orthopedic surgery and other health professionals who work with you. Can you explain a little bit about different kinds of orthopedic doctors and other team members?
Well, first of all, primary care physicians are able to take care of many minor musculoskeletal injuries within their scope of knowledge. When they feel that this is something more complicated than they wish to handle, they will make a referral to one of the orthopedists within the Palo Alto Medical Foundation. There are different members of the team who might see the patient initially. There is the orthopedic surgeon, and certainly for very complex problems, I would see a patient myself, but there are other people, physician assistants, medical assistants, other individuals who are capable of evaluating a problem initially and triaging, much like an urgent care doctor might triage, and may even be able to provide the initial care. All of it under the supervision of the physician, the orthopedic surgeon in this case. And we all function together as a team. We have an X-ray technician who will take pictures as necessary. We have a cast technician who will help put on a cast as necessary. We have people who will put on splints. We sometimes don't use a cast. We use pre-prepared removable splints that are more comfortable and more conformable. So there's a variety of ways to take care of injuries, and there are a variety of people who are involved in that care.
It's a great team. We're happy to have it, and with you as part of it. You mentioned that bones break if we get past their yield point. We put force upon them that's stronger than the bone itself. But are there risk factors, things that we as individuals can do to help reduce that risk, or certain people who are at higher risk because of age or other things put them at higher risk for breaking bones?
Well, in the pediatric age group, for example, children often break bones surrounding growth plates. The long bones of children grow in length through a cartilaginous area, that's cartilage instead of bone. It's called a physis. And that growth plate has two sides to it. One is the metaphysis or metaphysis, one side, where the bone has just formed, and then on the other side of the physis is called the epiphysis or epiphysis, where the bone is still immature. And that area is very vulnerable to fractures. And those fractures have to be dealt with very carefully because they not only involve function immediately, but they also involve growth. And so if the growth is arrested or changed in any way, then the child will develop abnormally. So those require a certain level of expertise and care. In the adolescent and young adult stage, the bones are very strong and usually will be injured in a situation where more energy is dissipated across the bone, such as playing football or soccer or other sports. As we get older, our bones lose mineral content and we develop osteopenia or osteoporosis, where the mineral content of the bone has been depleted and the bones are more vulnerable to fracture. It's a very interesting process that we haven't quite learned how to arrest yet, but in the elderly group, the fragility fractures that develop can sometimes be devastating because they're very difficult to treat because there isn't a lot of bone there to treat. So we have to use various means of internal fixation, lots of metal, lots of screws, rods, whatever it takes. It's interesting, I brought a little model, if I may.
Please.
To show what the inside of the bone looks like, where you can see what we call trabecular bone. It's cancellous bone, it's woven bone that is very light, not very dense, but has a certain amount of strength. And then surrounding the trabecular bone is cortical bone, which is much more dense and creates a cylinder around it. And if you can see the trabecular pattern here, there's not a lot of bone. And when elderly people lose their cortical construct, the bone gets very, very weak. It breaks, and then you have fractures usually surrounding a joint that become very difficult to fix. So that there are suggestions that primary care physicians will offer, such as taking calcium and vitamin D and perhaps some of the other medications that frequently can reverse the course of osteoporosis.
So as Dr. Golod says, important, particularly in older folks who have a fracture, should always speak with your primary care doctor about whether or not there's underlying thinning of the bone, osteopenia, or more dramatic thinning, osteoporosis, because we do have treatments to help strengthen the bone and can be very effective in preventing future fractures.
Correct.
So besides fracture care, a lot of what orthopedic surgeons do is joint care. Today we're going to mostly talk about the joints and the bones, not so much about musculoskeletal problems, but also we'll talk some about tendons and ligaments. Let's start with discussing shoulder troubles. So why are shoulders such a problem for people? How come so many people have shoulder troubles?
Shoulders are unique joints in that they do not have a lot of bony stability. So the socket of the shoulder is very, very small. It almost looks like a golf tee, and it articulates against the head of the humerus, the long bone of the arm, which is larger, but there's no inherent stability of the bone. Much like there is in a hip joint where the socket is very deep, in the shoulder it's very shallow. The reason for this is so that the shoulder can move in a hemisphere of motion. It can go in almost any direction within that hemisphere. And to keep the shoulder located, the body relies on ligaments that cross the joint and also on the support of the surrounding muscles. These muscles and tendons are very vulnerable to injury and frequently will become either torn or from repetitive use, squeezed frequently enough so that they become inflamed, and when they do, they become much more painful. When they are painful, they inhibit shoulder function, not so much because they're not working, but because they hurt so much.
So a few common problems we see in shoulder joints that people may have heard of. One is rotator cuff tear. That's something orthopedic surgeons would commonly be asked to help us. Can you explain what that means?
So, another model. The rotator cuff is a very broad tendon that covers the entire humeral head. So here's the head of the humerus, again, the long bone in the arm. It is covered completely by this tendinous structure that is actually made up of 4 different muscles, 3 from the back and 1 from the front. And together they enable the humerus to rotate. But more importantly, they help the deltoid muscle, which is the big bulky muscle that we all try to strengthen. They help that deltoid abduct, or bring the arm out from the side. Without the rotator cuff helping the deltoid, you cannot abduct your arm. Instead, if you fire the deltoid without a rotator cuff, let's say in a torn situation, your arm will do this. So the other function of the rotator cuff is to depress the humerus as the deltoid is lifting in this direction. That in physics is called a force couple, and it enables the arm to fluidly move up like this. Rotator cuff tendons don't tear as often as they become inflamed from overuse or impingement syndrome, where the tendon gets caught between the bone of the humeral head and the bone above it, called the acromion process. And what most people complain about is not so much a tear of the rotator cuff, but rotator cuff impingement, which in turn then leads to rotator cuff tendinitis.
It's a very complicated joint.
Yes.
And close to the joint you've described there is another joint here, the acromioclavicular joint. And what does it mean when someone separates their shoulder? They're talking about this joint, aren't they?
Right. So the true shoulder is the glenohumeral joint, where the humeral head articulates with the glenohumeral joint. The socket of the shoulder is a part of the scapula, the shoulder blade. Above the actual glenohumeral joint, shoulder joint, is the joint that the collarbone, the clavicle, makes with this bony ledge called the acromion process. And that joint helps to keep the shoulder away from the rib cage, so that with the pull of all the muscles to enable one to lift the arm up, the shoulder wants to go towards the center, wants to go where the muscles are pulling. The clavicle, the collarbone, is acting like a strut in the front end of a car and keeping that shoulder away from the ribs, away from the heart, away from the lungs. The joint that it makes with the acromion process is called the acromioclavicular joint, or AC joint. When a person falls on the shoulder or uses the shoulder as a battering ram, like in football, to block somebody, oftentimes that joint becomes disrupted. And that will be called a shoulder separation, as opposed to a shoulder dislocation, where the humeral head comes out and lodges somewhere down here.
And are shoulder separations and shoulder dislocations things that commonly require surgery?
Not always. Acromioclavicular separations most of the time do not require surgery if they're low-grade separations. When the clavicle comes way up and all the ligaments that hold it down are disrupted, many times those are operated on, but not always. Shoulder dislocations, first-time dislocations, are generally not operated on in the lay population. Professional athletes, high-grade amateur athletes, different circumstances, they may actually require surgery. But for most of us, first-time injuries are not operated on.
So Mark, let me ask briefly about just general categories of surgeries that you might perform on all different joints. So some joints need replacement, most won't. Some need repair of fractures, but also we've talked some about arthroscopy. What does that mean? What's an arthroscopy? What's an arthroscopy?
An arthroscope is a device that allows one to look inside a joint. A lot of doctors use scopes. General surgeons use laparoscopes as an example. This particular device is usually about 5 millimeters in diameter, about the diameter of a pencil, that has a light source, a fiber optic light source surrounding it to illuminate the inside of the joint. It also has a jacket that allows the influx of fluid into the joint to cool the joint and also to wash out blood and debris so that one can see. And in the center of the arthroscope is a lens that transmits an image via a very small camera back to a TV screen. And so the surgery is done indirectly. So a very small hole is made in a portion of the joint, allowing the scope to be inserted. Several other holes are made then to allow outflow of fluid, and then another hole perhaps for instrumentation, so that we have tiny little scissors, we have little motorized devices that suction out debris, or we can remove portions of diseased tissue. And it's made surgery in the orthopedic arena much less painful and the recovery much faster.
Let's talk about knees next. That's a common joint that would require arthroscopy.
Right.
What kinds of knee troubles would require an arthroscopic surgery?
Well, the knee is another complex joint, but the most common reason to arthroscope a knee would be to deal with a torn meniscus. So there are a lot of engineers and chemists in Los Gatos who would understand what a meniscus is in a test tube. In the knee joint, the meniscus is a piece of cartilage, actually two pieces of cartilage, one on the inside of the knee and one on the outside, that help the two bones to share load across the joint. The reason for the meniscus is that the femur is made up of two condyles that are round, and the tibia is a relatively flat surface. If you have a round surface on a flat surface, you have point contact. In order to distribute the load better, the menisci surround the two bones and increase the surface contact area so that the ends of the bones, particularly the articular cartilage that coats the ends of the bones, is not overloaded and doesn't degrade. If you have a torn meniscus, then it no longer shares load quite as well, and the articular cartilage is vulnerable to overload and developing arthritis. Another explanation for the importance of the meniscus, the menisci, by virtue of what they do, are very stable when they're compressed. So when you're standing on your extremity and compress the meniscus to share the load, they like that. However, if you suddenly change directions or hyperextend your knee and you create shear forces across the meniscus, it's subject to tear. In anticipating your next question, the importance of the anterior cruciate ligament, not only for stability to enable one to participate in a sport, but it also prevents the rotation of the femur on the tibia and thereby protects the menisci. If the ACL is torn and you lose the rotational control, then you're more vulnerable to tearing a meniscus, which is why, particularly in young people, we tend to recommend an anterior cruciate ligament reconstruction, not so much to make star athletes again, although that's important, but to prevent arthritis in later years, which unfortunately the youth don't get. They don't recognize what happens when they get older. So in a younger person, we might suggest an ACL reconstruction. In an older person, depends on activity level and a lot of other factors.
And Mark, do you do that reconstruction of the ligament, the ACL inside the knee, do you do that through the scope as well?
It's arthroscopically assisted. For the most part, it's still 3 or 4 little holes. One hole is a little bit bigger to allow the insertion of the graft. But that brings up a whole other subject, and that is, what do we use for an ACL graft? And that's a big topic of discussion when we make the recommendation for ACL surgery, because we can take something from the individual called an autograft. A very common piece of tissue that we use is the patellar tendon, which includes a block of bone from the tibia and a block of bone from the patella. And so we have this graft that's about that long, which turns out is proportionate to the distance required to replace the anterior cruciate ligament. Those grafts are very effective, however, they require an incision, and there's some morbidity, some pain involved with taking a piece of yourself. But we also have the ability now to use cadaver material, so-called allografts, where we borrow something from a deceased individual who's given permission, and after the kidneys and the livers and the corneas are harvested, then the orthopedic surgeons take bone and take tendons and other material, some of which can be used for ACL grafts. The advantage to using cadaver grafts is that you don't have to take something from the injured individual. There's no morbidity then from making an incision, and the surgery is almost all arthroscopic, so the recovery is a little faster. Disadvantages are that they are not sterile. So they are prepared very carefully and the donors are screened, but there is a risk, very, very small, of contracting a communicable disease. So there's something to talk about and something to think about if you are looking towards an ACL reconstruction.
Okay, so we've talked a little bit about the meniscus and the ACL ligament. Tell me, if you would, a little bit more about other ligaments in the knee and why someone might need your help for those.
The most commonly injured is the anterior cruciate ligament that we've talked about. Another ligament that's commonly injured is the medial collateral ligament, which is a strap ligament on the inside part of the knee that keeps the knee from opening up. So the knee joint bends, but it's not supposed to open side to side. If there is a blow to the opposite side of the knee, in football referred to as a clip, you watch the referee next time, that's a clip. The person may receive a knee, let's say, to the outside of his own knee that causes a major load in this direction that will either rupture the collateral ligament or can cause a fracture on the tibial plateau. That the tibia is this bone that connects the knee to the foot. Sometimes the compressive load that is delivered by the opposing force can cause this bone to collapse. So either this bone breaks or this ligament, the collateral ligament, tears. Collateral ligament injuries generally do not need surgery to repair. They can be treated in a knee immobilizer, which is a hinged device that is removable and just protects the knee while the ligament is healing. Tibial plateau fractures almost always need to be repaired because they generally will cause depression and irregularity of the joint surface, and as discussed before, you can't have that. The joints need to be perfect, otherwise we get arthritis really fast.
Well, you talked a little bit about fracture of the tibial plateau. I'd like to talk about a different kind of fracture now that is very important, especially in the elderly population. We see a lot of hip fractures. So, Mark, if you could please tell us a little bit about hip fractures, why they occur, and what's so important about them.
Well, it's important because there are a lot of people who have hip fractures, and young people get hip fractures too, but generally not as frequently as the elderly, and the major reason is because of osteoporosis that we talked about before. So the bone becomes very, very weak, and the elderly people sometimes lose their balance and fall. You and I might fall and just get up and go about our business, but the hips are particularly vulnerable in the elderly population because of the osteoporosis, and also because of the fact that the hip joint is made up of the femur, this long bone that connects the hip to the knee. The head of the femur articulates within the joint, and so in addition to that, there are two bumps on the hip called the trochanters, greater and lesser trochanter, and they have very powerful muscles that attach to them that help propel us. The hip abductors help bring the hip out this way, but also help to stabilize the pelvis when we're walking. And then on this trochanter, there's another powerful muscle called the iliopsoas that helps us lift our legs, let's say, to climb stairs. At the moment of impact, when someone is falling, these muscles are pulling violently to protect ourselves so that we don't fall too hard. But when energy is delivered across the joint, what happens is the bone breaks, but not only in one plane, but you often get fractures that consist of at least 4 pieces of bone because of the pull of the muscles. So you might break through the neck of the femur. The lesser trochanter comes off because the iliopsoas is pulling it off, and the greater trochanter comes off because the hip abductor muscles are pulling it off. So you wind up with a fracture that is broken into 4 pieces. Another common kind of fracture in the elderly is a femoral neck fracture. So we refer to long bones as head, neck, shaft. Another common place is a fracture through the neck. The 2 fractures that I just described make up the majority of hip fractures, and they're treated very differently. A neck fracture sometimes doesn't require anything more than just 2 or 3 screws placed from the side of the femur through the neck and into the head just to stabilize it and keep it from separating. And those will often heal. The ones that are displaced, where the neck breaks and the head comes off completely, those frequently require joint replacement, either replacing the head alone or a full hip replacement surgery. The trochanteric fractures are usually fixed with a device that either includes a screw, a lag screw that comes from about here up through the neck into the head, and then a side plate that connects the whole apparatus here to the shaft. An alternative means of fixing this is to put the lag screw up into the head and neck, and then a rod down from the top and connect the two. So the rod goes down and the lag screw actually goes through a slot in the rod, and the two are coupled together with a locking screw. The whole purpose of that is to stabilize the fracture so that the patient can get out of bed right away and start walking on it, because the risks of prolonged bed rest in the elderly are devastating. Before hip fixation techniques were initially developed by a fellow named Smith Peterson, something like 50% of the people who had a hip fracture would die just from bed rest. And now that number is dramatically reduced, and very few people die from hip fractures.
So we've come a long way.
Yes.
Are there other technologies that have changed during your career for other joints or other orthopedic surgeries that you've seen major changes in?
Everything has changed. I've been practicing for 40 years, and almost everything I learned as a resident has changed.
One thing I commonly hear is patients tell me, oh, the orthopedic surgeon told me I'm too young to have a joint replacement. What does that mean?
Joint replacements are actually resurfacing of arthritic joints. They are wonderful for restoring function and eliminating pain. They're almost miraculous in what they do for people. They give people back their lives. I've been told that so many times by so many patients. And what they are basically is removal of bone and gluing on, or in some other way fixating a device onto the bone on either side of the joint to replace the diseased joint. With that, however, come certain provisos, and one is that the joint must last a lifetime. If it is to fail, then what's the point in doing it? The original joints, the first successful total joint was developed by a fellow in Great Britain, Sir John Charnley, who in the 60s discovered that he could fix metal into bone using an acrylic grout, and that he could reduce friction across the joint by using a plastic interface, not metal on metal, but plastic on metal. Charnley revolutionized joint replacement in orthopedics. Since then, the original Charnley hip has been supplanted by other designs, yet Charnley's original design was very successful, and a lot of his hips lasted for many, many years, more so than people had predicted. The original thought was joints last 10 or 15 years or so, and I still hear that in my office, but that isn't true. They actually last longer now, assuming that they're put in properly and that a good design is used. But everything in orthopedics has evolved. The hip joints have evolved to the point where you no longer need the grout. We use a rough surface on the implants that allows the bone to grow directly into the metal on both sides, so on the socket side and on the stem side. It's rough coated. And the reason that this can happen is because the metallurgy is so much better now. The stems for hips are made out of titanium, which is a very flexible metal. It almost equals the flexibility of bone, so it doesn't shield the bone. And yet it has a very high yield point, so that you can cycle a titanium stem through many, many, many cycles, and they won't break. So the hips now they're lasting a long time. I mean, there are very few hip failures, except for certain circumstances. The knees initially were not that successful because of design considerations. There were many, many knees on the market. Almost all of them failed until a design was created by an engineer at the Hospital for Special Surgery in New York. His name was Peter Walker, and he designed a knee that was called a total condylar knee, where the tibial tray was adjusted so that it had a keel on it, much like the keel on a boat. And like the keel on a boat, it provides a lot of stability so that tibial component can't rock and it can't rotate. The femur, the part that goes on the long bone, the femur, is inherently stable because it has 4 sides to it. Actually, five cuts that are made. And so together with the new design of the tibia and the femur, the knees are now lasting a whole lot longer. And the old adage that, well, it only lasts 10 or 15 years is no longer true. But if you put joints into a younger individual, younger people do more. They're more active. They run, they jump, they hike, they abuse their new joints. And so the failure rate is likely to be somewhat higher. Plus, they live a lot longer. So if you put a knee into a 40-year-old and the life expectancy, let's say, approaches 90, this joint needs to last 50 years. And what's the likelihood of that? Well, it could, but we try to keep younger people from having total joints. However, some people need them. There are people whose knees have just been ruined and their lives are miserable, and so recognizing the risk of premature failure, we will do total joints in some young individuals. There are also people who have inflammatory arthritis, such as rheumatoid arthritis, who desperately need total joints because their joints are so inflamed. And so we do joints in 20-year-olds who need them. But it all depends on the individual and the circumstances, just like anything else that we do. Everything really has to be tailored to an individual.
I hear you saying careful selection of who should have total joint replacement is important. To make sure that they're going to do well with surgery and the outcome of surgery, but that new technologies in the last few decades have dramatically improved the quality of the joints and how long they're likely to last. And also that modern joints are very, very strong, but also very flexible, much like our own skeleton is. Is that a decent summary?
Yes.
You know, Mark, you didn't mention shoulders. Do you ever do shoulder replacements?
Not nearly as frequently as hips and knees. The hips and knees are more vulnerable to developing arthritis because they're weight-bearing joints, and the stresses across those joints are much higher. Shoulders do a lot of repetitive activities, but without as much load carried across the joint. However, some shoulder joints, because of poor biomechanics, let's say from an old injury where the ligaments have been stretched, can develop arthritis as well. But before doing a shoulder replacement, one might look toward other less invasive means of treating the arthritis, such as cortisone injections. Even arthroscopic procedures on the shoulder can sometimes prolong its useful life before joint replacement is needed. But shoulder replacements have also evolved to the point where they are now pretty successful and are lasting longer than expected and provide the same kind of relief and return to activities that knee and hip replacements have provided.
I hope that you, our viewers, have learned something today on the program with Dr. Golod and understand that our greatest desire here at the Palo Alto Medical Foundation is to provide the most up-to-date, technologically advanced care we possibly can. Thank you for joining us, and we'll see you again next time on Health Connections, KCAT Television, Los Gatos, Monte Sereno.